So collaborative care, our immediate goals, anytime, and then we're not talking about complications. We're talking about if they get a spinal cord injury, our immediate goal is always, someone said it, airway, right? ABCs. So airway, breathing, ventilation, O2, and circulating blood. We want that mean arterial pressure greater than 90. So while our focus is ABCs, the most important thing we can do is to prevent any further cord damage. So we're going to stabilize that C-spine, get IV access, and start imaging. All right, get that CAT scan, see where the level of injury is, if there's a suspected spinal cord injury. Ongoing, so after they immediately come in, what we're going to continue to do is the vital signs, urine output, right? We want to make sure that they're having adequate urine output. Either they have to have an indwelling urinary catheter initially, or making sure that they know how to intermittent cath, because we don't want them to get that bladder distension, because we don't want them to develop the autonomic dysreflexia. Monitoring cardiac, O2, level of consciousness. Keeping them warm. Remember, they can't regulate their body temp. Monitor the urinary retention, the hypertension. If they're complaining of a headache, if we take vital signs and we see that the blood pressure is high, we've got to think about that autonomic dysreflexia. Got to find the cause. And get a good assessment in history. Oh, sorry. Crunch in front of the speaker. All right, go back to your respiratory slide. So if our biggest concern about death is this ineffective cough, the atelectasis, the pneumonia, the infection, how are we going to treat this? We need to monitor breath sounds, right? Listening for any crackles or changes. Is their respiratory effort good? Are they taking big, deep breaths? Do they have an effective cough? What color is their sputum? You guys are at the bedside. Their families are going to be the ones with them, so we're going to teach them this too. If you notice that your, loved one is coughing up yellow sputum, you need to call the doctor. If they develop a fever, you need to call the doctor because they may be developing pneumonia, okay? If they can't feel, they don't have motor or sensory function, then they're at higher risk of developing this and not knowing. CPT, remember that from cystic fibrosis in level 3? The beating of the chest. They might need CPT to get those secretions moved. Good pain management. They may need that augmented cough where you help them cough, or teach their family that a couple times a day they have to do where they hold underneath the diaphragm and kind of push up when they cough to help move. Suctioning, teach them about incentive spirometer. Again, the patient-family teaching is really important because most of these patients are being taken care of outside of a hospital setting. But this is going to be one of their number one complications. Cardiovascular, they got bradycardia, right? Their heart rate is low because of the sympathetic nervous system is not working on the heart rate. So they need medicines. They need atropine to keep that heart rate up, especially if the heart rate's below 40. Some patients, depending on the level of injury, may need a permanent pacemaker, which Ms. Lewis is going to talk to you about. She's very excited. She can't wait. So again, when you're thinking about all these things, think about what's happening in the body. What then is going to cause, if my sympathetic nervous system is not working on my heart rate's going to be low. Then I need to know as a nurse then that they're going to need atropine or pacemaker, right? So again, we're going to give you questions. NCLEX is going to give you questions, and they're not going to say, your patient with a T6 spinal cord injury has a heart rate of 40. What medicine are you going to give? They're going to give you a scenario of a patient that comes in and give you a bunch of vital signs and say that, you know, maybe the vital sign and it shows a heart rate of 40, and they say that they're symptomatic, like they're having signs and symptoms of low cardiac output, and they want you to know, you know, what would be your first intervention for this patient, or what would be something that helps them. So that this is where your thinking needs to go to. So they have the vasodilation, right? They have hypotension. So we're going to give them fluids, but are we going to just open the bag and let those fluids run like crazy? No, because this is, you know, it's because of the vasodilation that they have it. So we're going to give them some fluids to fill that space, but we don't want to fluid overload them. We're going to give them an isotonic solution, right? Because we learned that are the cells dehydrated? So we're not trying to push fluid in, right? We're not trying to get fluid out of a cell. We're just trying to fill intravascular space. So, now that makes sense to me because I know an isotonic fluid fills intravascular space. Most likely, they're going to need some kind of vasopressor, right? They need something that's going to vasoconstrict. We have the vasodilation going on. We need to work against it. We're going to monitor their cardiac output, vital signs, their blood pressure, heart rate, hemoglobin, hematocrit. And we're going to be very careful about vagal maneuvers. What do vagal maneuvers do to your heart rate? Lower it, right? So no turning, no suctioning, no yawning. No, that was not. Urinary. Oh, did I go too fast? I'm sorry. You want me to go back? Real quick? Okay. I saw a couple of you get the big eyes. That tastes horrible. All right, so urinary. So if they're at risk for urinary retention, we cath them, right? Makes sense? When we can, we want it to be intermittent. We don't want an indwelling catheter because an indwelling catheter increases the risk of infection. And the patient needs to be taught a schedule. The family needs to be taught a schedule. This needs to be done every 3 or 4 hours. Patients are at risk for infection, so we're going to monitor. We all know the signs and symptoms of infection. I hope we do by level 4. Fever, chills. Make sure they know aseptic technique. This needs to be sterile. Check the patency of the tube. So if it is indwelling, or even when you cath them, if you get nothing out, make sure that the tube is patent. They might need fluids. So once they get treated, and once we have that vasodilation under control because we're treating it, we want to make sure that they're drinking enough fluids. They don't get dehydrated. They may need some anticholinergic drugs, like Ditropan. With the neurogenic bladder, it can cause those contractions. So Ditropan helps decrease those contractions. An alpha adrenergic blocker to relax the smooth muscle. Antispasmodics like Baclofen. And a lot of times they can do a urinary diversion surgery, which is pretty awesome. Has anyone ever seen it? They actually take the ureter and divert it so that it actually comes out the belly button so that they can cath themselves through the belly button. Because obviously sitting here, I'm so glad no one's taping me. So, I mean, obviously like cathing like this all the time yourself would be awkward, right? Men is a little bit easier, but for a female, that's pretty hard to get in the right position to aseptically cath yourself. So the urinary diversion surgery makes it much easier, and they just, access right through the belly button. It's pretty cool. Or they make a little incision down in the lower abdomen and they can do it. Referrals and supplies is going to be a big thing because a lot of your patients aren't going to have the finances. You are going to see those who are home health nurses. I don't know if you've taken care of these patients. These are the patients that use the same catheter 10 times in a row because they don't get the right supplies or they don't have the right prescription. So when they come into the hospital, this is our time to say, do you have enough supplies? Are you running out too soon? If they come in because of an infection, ask them things like, are you using a new catheter every time? Show me how you cath yourself. Maybe they just do it with their bare hands and no one's ever taught them. You can't assume that they know. So you want to, demonstrate to me. Show me how you do it. That's not how you do it. Let's try again. Let me show you how to take care of yourself. Or they might tell you, my prescription only gives me this many, or my insurance only covers this much. So they may need a referral to get more supplies or whatever. Because this is not something they're going to do one time. Again, this is lifelong for them. GI, if initially they have some hypomotility and we're worried about an ileus, we're going to throw an NG down them, right? Or get them Reglan. Reglan kind of moves things along. Everybody in the hospital is on an H2 blocker or PPI, right? Help decrease the hydrochloric acid that's in the belly so we don't have any risk for stress ulcers. Because if we get enough ulceration, that's when we can develop the bleeding, or because of the ileus, that can develop the bleeding. We talked about this. We're going to monitor the blood pressure, monitor the abdominal girth, look at hemoglobin and hematocrit if we're worried about a bleed. Neurogenic bowel. They need a bowel program. So you want them to sit down. So like every day, they're going to sit on the toilet at 5 o'clock every day for this amount of time. They need a specific program. They may need some kind of rectal stimulant, like glycerin. Obviously, lots of fiber, lots of fluids in the diet. A stool softener if needed. Most likely they're going to be on one. If needed, you can do an oral laxative, but you're not supposed to use that regularly. Okay? They do have a really cool surgery that's like the urinary diversion surgery, where they take the bowel and bring it out, and the person can irrigate their bowels and like kind of flush themselves out if they can't control it. But the big thing is, again, we want to prevent constipation, because what can constipation lead to? The big bad thing that we don't like. Not an ileus. That complication that we talked about. That autonomic dysreflexia, right? Because it's a painful stimulus that can cause the SNS to kick into overgear. All right. Skin, obviously, good assessment. We don't just look at it, we touch it, make sure everything looks good at least once a day, and especially over bony areas. There is no excuse ever for you not to look at your patient. I know it's embarrassing to look at their butt or whatever, but you should be turning your patient and looking at them. If they aren't able to get up and move around on their own, you need to be looking. How many of you can look at, that's kind of hard. Reposition every 2 hours. They have special mattresses, chair cushions. Nutrition is really important for these patients. They need enough protein in order to prevent skin breakdown. Albumin is a good indicator of whether they're getting enough protein. So their prealbumin and albumin. And then we're going to protect against any thermal injury. They can't feel heat and cold. So if you put a hot towel on their leg, they're not going to feel that it's too hot. Have you guys ever gotten a pedicure, right? And you stick your foot in the water and you're like, oh my God. And they're like, oh, is that too hot? Or they put those towels on you and you're like, whoa, give it a second. And they air it out some. They can't feel that. So you'll put something on them thinking it's okay and you can burn them. So with the, I suck at saying this word, poikilothermism. Because they can't regulate their body temperature and their body temperature fluctuates, you have to monitor their environment. They can't tell you that their room is too hot or too cold. And again, the higher the level of the injury, the worse off it is. So when you're giving them a bath, if you take all their blankets off and you're like wiping them down, they're not going to feel that they're freezing cold. So you have to be very careful about making sure that when you bathe the leg, you're keeping the rest of the body covered because they can't regulate that temperature. You have to take their temperature frequently. And then, like I said, you don't want to overly expose them and you don't want to overload them either. You don't want to put so many blankets on them that they start burning up because, again, they can't tell you that they feel hot. Metabolic needs. We're going to monitor fluid electrolytes, especially if they have an NG tube. We can take too much out. We talked about weight loss. They need that high protein, high calorie diet. Evaluate their swallow, especially the higher the injury. If they have a C4 or higher injury, they may not be able to swallow. So they may need an NG tube or G tube. Obviously, the best way we want to feed them is by mouth. If we can't feed them by mouth, like I said, we'll get a G tube. If we can't get the G tube for whatever reason, because of the ileus or neurogenic valve, then that's when we go to TPN. That's the last resort. Supplements, fiber. And then we talked about this anorexia a little bit. It's the one thing they can control, and they want to control it. So if they're not eating, you want to assess the reason why. They need to come up with a contract or a plan that they're willing to stick to. And you want to make it a pleasant eating environment. Don't turn this into a control thing. You might as well like fight with 22-year-olds. You have to let them have some control over it. Show them, especially like if you can write down their foods, write down their calories, show them, you know, black and white what they're doing and what they need to do and what they're willing to do. You have to work with them. We talked about some of this. SCDs, right? Range of motion, getting physical therapy involved, occupational therapy. They're often on heparin or Lovenox. And you should be assessing their thigh, their calf every shift. You want to look for any redness. They're not going to feel tenderness, so they can't tell you that, but you can look for any redness or edema. Again, the big thing with DVTs is we want to assess if they have one because we don't want them to develop a pulmonary embolism. Respiratory tends to be their biggest complication, but this is the leading cause of death. And this should everything we're talking about is all stuff you already know, right? All stuff that you guys are doing. So none of this is new. It's just think about what's going on in the body. So musculoskeletal, again, you're going to properly immobilize. They might need to be in traction or braces. When they log roll, you want to when you turn, you want to make sure you log roll them. The spasms, baclofen, contractures, range of motion, again, all things that you guys already know. So this is not just a nursing issue or the physician issue. This is a big interdisciplinary team that needs to be involved with this. When we get them in the hospital, when we see them in home health care, that's when we can get involved and get them the services that they need. All right, this is where everyone starts to giggle. So for males, for males and females, I'll put it all up there. Be very specific. Use medical terms. Sex is very much still a part of their lives, and just because the organs may not work the way they want to doesn't mean that the sexuality drive still isn't there. And it's always a touchy subject that people don't want to talk about. So they're going to be embarrassed to ask, but we shouldn't be embarrassed to talk about it. It should just be matter of fact, just like everything else. We want to educate them on alternative methods, about how to get stimulated, how to get an erection, things like a vacuum device or Viagra. Because, what if it's a married man, or even if it's your girlfriend or whatever, or your partner, they're still going to want to have activity. So there are surgical procedures too. Women, you really want to educate them about birth control. It's very common they think they can't get pregnant anymore, and they can. So they can get pregnant, and because they're wheelchair bound, they may not know that they're pregnant until they're 6 months along, 7 months along, and really showing. So then they miss that opportunity of good prenatal care. They need to have a good birth plan. They need to have their partner look for signs and symptoms that they may be in labor, because they're not going to feel contractions. So their delivery is going to be different. And lastly, we need to work the psychosocial. We need to maintain hope for them. And by doing all these things and developing, what a different lifestyle change. It's significant. We're changing how they go to the bathroom, how they eat, how they get about, how their family functions. And we need to give them the best hope that we can give them by taking care of them. But they are going to be angry, mad, aggressive, sad. And they're going to be all of these, and they're going to fluctuate with these emotions. And we have to allow them. Do not tell them it's going to be okay. It's not okay. Don't tell them that, it could be worse, you could be dead. How many of you want to hear that? And I don't think that we say these things to be uncaring. I think it's just a knee-jerk reaction. But we need to be careful. They don't want to hear those blanket statements. If they say this sucks, you say it does. And let them be angry. Let them. Because there's a difference, like I said, between they're gonna accept it. Hopefully they will accept it. And they will make adjustments to it. But they're allowed to have that mourning period. There's been a significant loss. They want counseling, support groups. They want to talk to people that have gone through this too. You that are walking around and whatever don't know what they're going through. We don't. When my mom died, I did not want to talk to someone who still had their mom. I hated them. And then I felt guilty for hating them because I still wanted them to have their mom. And then I felt guilty for feeling guilty. It's a horrible thing. It's this cycle. They want to be with someone who understands, who's not going to say you shouldn't be angry or, they want to meet with those people. So get them into support groups, get them into counseling with those people that can relate to them. They may need drugs, antidepressants, something to get through the initial period. Sympathy isn't helpful for them. Like I said, they don't want your sympathy. Again, I'm not going to spend a lot of time on the nursing diagnosis. There they all are. And our goal is the optimal level of neurofunctioning. That's why we want to make sure our main goal is to prevent any more destruction of the spinal cord. We want minimal to no complications of immobility. So no skin breakdown, no infections, no UTIs. We want them to learn skills and be able to take care of themselves as much as possible. They have to have some sort of sense of control. We want them to return to their home or their community. So maybe they were a nurse and maybe they can't be a floor nurse anymore, but we can get them and they can be a clinical educator now, right? Maybe they can't be on the site anymore, but they have 20 years of experience and have some really good insight. So help them try to find resources, find a job, get back into their home, how they can still contribute to their family and feel useful. Everybody wants to feel useful, right? They want to know that what they're doing is for a purpose. And not that they're just kind of mooching off of people or dependent on people all the time. Again, rehab, it's lifelong. Again, the goal is to function at the highest level. We already said it's interdisciplinary. We're getting everybody involved. Physical therapy, occupational therapy. And these are all organized around the patient's goals and needs. What does the patient want? It's not about what you want or what you think is best. So the patient's expected to be involved, and we want to encourage them. And obviously we evaluate, how are we doing? Are they ventilating good? Because that's a big complication for them. Do they have intact skin? Do we have no infection? Do we have good bowel management? Did the patient is not developing signs and symptoms of autonomic dysreflexia? No complications of immobility. They don't have contractures. Are we doing all the things that we set out? All right. Does anyone have any questions? That is all of your test 1 material. Woohoo!